Today we are going to discuss about the plain radiography features of congenital heart diseases. The first radiograph shows a boot-shaped appearance of the heart. This is a boot-shaped heart which is classically seen in tetralogy of Fallot. The four components of tetralogy of Fallot are right ventricular outflow tract obstruction, due to which there is right ventricular hypertrophy, ventricular septal defect, and overriding of the aorta. Due to right ventricular hypertrophy, there is upturned apex of the heart, and there is also concavity of the pulmonary trunk and the aorta. These features result in the typical boot-shaped appearance of the heart. The next radiograph shows that the heart has assumed a figure-of-8 appearance. We can also call it the snowman-shaped heart. This is classically seen in supracardiac type of total anomalous pulmonary venous return. It is a condition in which all the pulmonary veins, instead of draining into the left atrium, drain either into the systemic circulation or into the right atrium. The cause of this snowman appearance is because the head is formed by the dilated left vertical vein, which is formed by the combination of the pulmonary veins, the dilated brachiocephalic vein, and the dilated superior vena cava, and the body is formed by the enlarged right atrium. This condition is of four types. In the supracardiac type, which is the most common type, all the pulmonary veins combine to form a common vein, which is known as the left vertical vein, and it drains either into the superior vena cava or the brachiocephalic vein. In the cardiac type, the pulmonary veins drain either into the right atrium or the coronary sinus. In the infracardiac type, all the pulmonary veins drain either into the portal vein or the hepatic veins or the inferior vena cava. In the mixed type, some of the pulmonary veins drain into the brachiocephalic vein or superior vena cava, others drain into the right atrium, and a few may drain into the IVC or hepatic veins. That is, the veins may have different drainage. It is the least common type. The mixed type is the least common type. In this radiograph, we can see that the heart has assumed more or less box-shaped appearance. So this is the box-shaped heart, and it is classically seen in Epstein anomaly. The condition is mostly sporadic in origin. However, few cases have been documented with maternal lithium carbonate injection, which is a mood stabilizer. In this condition, there is apical displacement of the septal leaflet of tricuspid valve, due to which there is enlargement of the right atrium and diminished size of the right ventricle. So there is right-sided cardiomegaly. In this chest X-ray, we can see that the heart has assumed an egg-shaped appearance, oval appearance, and the pedicle is very narrow. So this is the Avon string heart. It is seen in transposition of the great arteries. The pedicle appears narrow because of posterior displacement of the pulmonary trunk, which lies posterior to the aorta. In this radiograph, we can see that there is cardiomegaly. The pulmonary conus appears prominent, and the right descending pulmonary artery also appears prominent. There is also pulmonary oligemia bilaterally. So this is a case of Eisenmenger syndrome. It is a condition in which pulmonary arterial hypertension develops due to high pressure, high flow left to right shunts. Chronic exposure of the pulmonary arterial system to high pressure and high flow of blood results in increased vascular resistance, as a result of which there is right ventricular hypertrophy, and reversal of shunt. That is, the left to right shunt becomes right to left. And there is also pulmonary oligemia. This is a case of VSD in which we can see that there is cardiomegaly, prominence of the pulmonary trunk, the left atrial appendage, and also a prominent right descending pulmonary artery. It is also associated with pulmonary plethora. However, the pulmonary vessels are not properly visualized in the radiograph because of improper exposure factors. So we can give a diagnosis of VSD if there is cardiomegaly, left atrial appendage enlargement, and pulmonary plethora. It is of four types: membranous, which is the most common, muscular, inflow, and outflow. We can differentiate it from ASD because in ASD there will be no left atrial enlargement. Other features will be the same, but in ASD there will be no left atrial enlargement. Pathology of Cantrell. It is a very rare anomaly in which we get 5 types of anomalies. Ectopia cordis, which is associated with atrial septal defect, ventricular septal defect, or tetralogy of Fallot. Omphalocele due to deficient anterior abdominal wall. Diaphragmatic defect, which may lead to diaphragmatic hernia. And pericardial defect, that is congenital absence of the pericardium, which is most commonly the left pericardium. So this is a case of ectopia cordis, where we can see that there is a soft tissue density mass anterior to the chest. And this is a case of omphalocele, where we can see that air-filled bowel loops have herniated out of the anterior abdominal wall, and the peritoneal sac is intact. So this is a case of diaphragmatic hernia, where we can see herniation of air-filled bowel loops into the left side of the thorax, displacing the mediastinum in the heart to the right side. Usually congenital diaphragmatic hernia is of two types: Bogdalic hernia and Morgagni hernia. This is a case of Bogdalic hernia because it is left-sided. As we have discussed already, one of the features of pathology of Cantrell is pericardial defect. So the pericardial defect may be either complete absence of the left pericardium or partial absence. In complete absence, there will be leftward displacement of the left cardiac border, and also there will be interposition of lung tissue between the aorta and the pulmonary trunk because of the absence of pericardium between the two. There is leftward shift of the cardiac apex. So all these features result in the appearance of Snoopy dog. So this is the Snoopy dog appearance which we get in complete absence of the left pericardium. There is also non-visualization of the right cardiac border in absence of the left pericardium. This is a case of partial absence of the left pericardium. The pericardium is usually deficit in the region of the left atrial appendage or over the pulmonary conus. In this case, it is deficient over the left atrial appendage, so as a result of which the left atrial appendage has herniated out through the focal pericardial defect, and therefore it appears prominent. We can also see that there is non-visualization of the right cardiac border, which is a characteristic feature of absence of the left pericardium. And we can also see lung tissue interposed between the base of the heart and the diaphragm. This is due to the absence of pericardium, which normally fills the space. On lateral chest radiograph, we will see increased distance between the sternum and the heart due to the absence of sternopericardial ligament. So that was all for today. Thank you.